Great. For those of you who are just joining us, we're going to give other folks a second to log on. So please just hang out there for a second and we'll get back to you in a minute or so. Alrighty, I think we'll go ahead and get started because we're a couple minutes in. For those of you who haven't joined us in the past, I'm going to give my sort of standard disclaimer, which is that this is a webinar. It's open to anybody, but that it is specifically for folks who have their primary appointments in the School of Public Health. So if we talk about guidance or rules or stuff that has to do with the school, and you're like, I wonder if that applies to me, then you should check with, if you're in another unit as a primary at UW, you should check with the folks in that unit, or obviously if you have a different primary employer, you should check with your primary employer. Another reminder is that we do not use the chat box. Instead, we use the Q&A function, which you can see on your screen there. And we tend not to use the raising hand thing. It's just hard with this number of people to sort of track who's raising their hand. So if you want to share a resource, feel free to put it in the Q&A. But if you actually have a question, then please put it in the Q&A window instead. So with all that, welcome. We have an exciting agenda for today. We have two special guests from Public Health, Seattle and King County. They are Eva Wong and Sargis Pogosjans, who will discuss two of the data dashboards that they're using to track COVID-19's impact, especially on vulnerable communities, and to talk about how that's been informing their agency strategy to contain the disease. Before we launch into that, we're also going to talk about some exciting news, give you an update on recent well-deserved promotions within the school, and also slightly sad news for us, but probably happy for them, some well-deserved retirements for folks as well. And then if there's time at the end, we'll go through and do the two presentations after we do the announcements and do Q&A. If there's time after that, we can do some general announcements and Q&A. But just as a reminder, we switched to our summer schedule where we only have 1 hour instead of an hour and a half, so we may not have time to do the general stuff this week. So that's our agenda. Along with our two panelists from Public Health Seattle and King County, our other panelists with us today are Jared Baton, who's our Vice Dean for Strategy, Faculty Affairs, and Strategic Initiatives. He's a professor of global health, medicine, and epidemiology, and gets to provide announcements about promotions and retirements. We also have Janet Baseman here with us, who's our Associate Dean for Public Health Practice and a Professor of Epidemiology. Stephanie Farquhar, who is Acting Associate Dean for Education and a Clinical Professor in Health Services and DEOHS, who's going to moderate the discussion with our guests. And Lisa Manhart, who's our Associate Dean for Research and Professor of Epidemiology. So with that, I'm going to turn it over to Jared, who has some slides to share with all you guys about promotions. Jared, we're seeing your calendar.
Oh, do you want my calendar? You can have it. Try again. Screen share this one. Hi, everybody. There we go. It's July 1st, which is when promotions in the school take effect. And so we're just have a couple slides to congratulate faculty promotions and awards of tenure in the school. So there's 2 slides of individuals who are core faculty in the school, primary and joint appointments in the school, who have new titles as of this year. And here are their titles and which departments they are in. So congratulations to Marco Corone, Amanda Fretz, Julie Quee, Paul Hebert, Paul Drain, Jeremy Hess, Jesse Jones-Smith, Tim Thornton, Alison Littman, Emily Williams, and Ali Soljay. So yay! We have a whole list, which I'm not going to read, of individuals who have affiliate, adjunct, and clinical appointments in the school, and there you all are. Congratulations to every single one of you. And as Hilary mentioned, we have some well-deserved retirements. And many of these individuals are going to continue to be working and teaching and mentoring and other things in the school. So they're not going anywhere. They just get to change their title and hopefully relax a lot after years of hard work. So congratulations to Ann Downer, Barbara McKnight, King Holmes, Aaron Katz, Mike Rosenfeld, Kathleen Peterson. I'm smiling so much because these are some of my favorite people who've mentored me in the school, all of them. To Noah Weiss, Mary Lou Thompson, John Wilner, and Ann Vanderstoop. So congratulations to all of you on careers well done. So thank you, everybody, and enjoy the rest of the webinar.
Okay.
Thank you, Hilary and Jared.
Yep.
Oh, yep.
I was just going to say, I'm turning it over to Stephanie. It's all you.
So Eva, I invite you to share your screen, and I think you're speaking first, and then Sargis, and then we'll lead into Q&A.
So Stephanie, are you going to do the detailed introductions to Eva and Sargis, or do you want me to do it?
Oh, sorry. Yes, go ahead.
Okay. So let me tell you a little bit of information before Eva speaks. So Eva is an applied public health practitioner and researcher who serves as the senior maternal and child health epidemiologist at Public Health Seattle and King County. She co-leads the evaluation team for King County's Best Starts for Kids, also known as BSK, program. And Eva also works closely with internal public health programs and with students pursuing public health and nursing graduate degrees. She's a clinical assistant professor in epidemiology here at the School of Public Health and earned her PhD in Epi and an MS in environmental health. And then our second speaker, who I'll introduce now, but who will speak right after Eva, is Sargis Pogosjans. And Sargis is a communicable disease epidemiologist who's worked with Public Health Seattle and King County since 2017, where he leads surveillance data analysis for Public Health Seattle and King County's COVID-19 response. Previously, he worked as an HIV/STD partner services epidemiologist at the Texas Department of State Health Services, and he has an MPH in epidemiology and biostatistics from UC Berkeley. We really appreciate you guys being here to talk with us today, and like I said, Stephanie will moderate the Q&A after the two of you are done with your presentations.
Well, great. Thank you so much. And thank you for having us today. It's so great to see that list of well-deserved retirements. Some of them were both people that I TA'd for when I was at school, as well as were on my own committee. So just really amazing list of people who get to be emeritus professors. So thank you so much for having us today. Can you see those slides? Great. So you all are well aware of COVID and the different impacts of the COVID illness itself. But what I'm here today is to talk about something that might be a little bit different, which is We know that community mitigation is one of our key measures to play a role in the response, but all of us have been affected by different closures, the business closures, the school closures. We're having this whole meeting over Zoom. I mean, like, we've all become conversant in these different technologies, and we know that impacts follow some of these community mitigation measures. So we realized early on that not only do we need to be measuring some of the COVID impacts, but also what are some of these other impacts? And so we've actually put together a project that's examining and focused on the economic, social, and overall health impacts of the community mitigation measures. In this specific project, we're examining some key data points and really focus on that non-pharmaceutical intervention. We have two main ways that we're sharing out information. The first is a rapid cycle methodology where we have this dashboard. We're putting out updates on that on a weekly or a monthly basis, very rapid cycle. The second way we're sharing information is using these topic-specific short briefs. We know with the dashboard we can put out a little bit of information and update it on a regular basis, but it doesn't provide more of that story and more of that context. So we are able to do that in these topic-specific briefs. We have a couple out so far around around unemployment and transportation, and we have some additional briefs coming up soon around the topics of behavioral health and food insecurity. So the whole point of this project is not just to put out data for data's sakes, but really to inform what happens next. What do we have to be sure that we're monitoring to understand what we can do to take actions to moderate the impacts that are resulting from these community from these community mitigation strategies. So the work that I'm going to be presenting on is actually a joint project funded in part by the Washington State Department of Health, Public Health, Seattle and King County, and the CDC. So this is just an overview of our dashboard. When you go to this online webpage, you'll see a grid, and there are a number of different indicators that we're monitoring here. What you see on the screen in front of you is things like unemployment, housing, traffic and different transportation measures, internet access, domestic violence, food insecurity, healthcare access, mental and behavioral health. These are key metrics. The idea here is not to be comprehensive, but rather to provide what are the key metrics that we can look at to understand what's happening. The metrics here are designed to answer some questions about not only is what's happening quickly and almost on a week-by-week basis, but also we have a second layer of information where we're wanting to understand who is being affected and are some groups being disproportionately affected. And I really want to raise that piece up because we know that some groups actually are being disproportionately affected by these community mitigation measures. And when you layer that on top of generations of structural racism, you're really just compounding some of the effects. Your local health department, Public Health Seattle, has declared that racism is a public health crisis. And so I don't want to lose that lens. So the indicators that are on this dashboard are we selected them based off of the best available science that's out there. We're using information from prior pandemics on if you do these non-pharmaceutical interventions, what might happen, as well as information really considering the social determinants of health framework. And obviously we need to have available data to do this. So that gives you a sense of the data that's on there. And that was the overview, and I want to dive into what's next. I am actually sharing this presentation as a set of slides and not using the interactivity that you will see when you go online, just because of internet concerns and stuff like that. But when you go online, if you had clicked on one of these boxes before, you'll get to some information like this. So this is just a sense of the social service needs that are occurring. Crisis Connections is a phone line that you can call. You call 211, you talk about what your needs are, and they will try and link you up to some different resources. So we do see that food and housing are the top needs that people are calling around this spring and now summer. And when you look at who is calling, on the left side of this graph is the race ethnicity distribution of the King County population. And on the right side, in kind of the teal or green, is the race ethnicity of people who are calling and making these calls requesting social services. So you can actually see that people of color are disproportionately the ones who are calling to get these services. I'm not going to go over all of the different data points on the dashboard, but really just give you a flavor of what are some of the things that we're finding. So this is a piece around unemployment. So you can see that King County residents filed almost 400,000 new unemployment claims just in the last few months. That is 20 times more than what usually happens in the same time period last year or the year before. So it's pretty significant. And as you look at the policy timeline, which is down here on the bottom part of the slide, you'll see that just really immediately after some of the business closures, that is when unemployment claims really began to come into the unemployment system. And there have been a number of different efforts already to mitigate some of these impacts, like extending the when you have to file your taxes, or eviction prevention programs, or stimulus funds that people have gotten. And when you also look at where people are living who are filing these funds, who are filing for unemployment, you see that they're disproportionately coming from South King County and South Seattle, and that is where we see this, the vast majority of our communities of color. When you look at it by other demographic characteristics such as age, race, and sex, you see that actually folks who are have a lower educational attainment, who are people of color, as well as people who are younger, do disproportionately file for claims. The impacts are not being experienced by everybody. And when you look at the occupations that these people are working in, it will come as no surprise to you that these folks who are filing for unemployment are disproportionately employed in accommodation and food services, arts and entertainment, and other industries that have had to have many closures in the last few months. So I talked about the social determinants of health framework that we're using. So people are filing for unemployment, they're losing their jobs. It will come as no surprise to you that now some of the social service programs are seeing increased enrollment. This is a graph looking at folks who are applying and enrolling in the basic food program. And this graph on the bottom shows 2019. And then as you come into the spring of 2020, you can see that's really jumped up. And again, disproportionately, folks are enrolling from South Seattle and South King County. So that's just a flavor of the kinds of information we do have on our dashboard. I want to leave you with a couple of other tools that I want to bring to your attention. The first is our COVID-19 vulnerable communities data tool. You can find that, as well as a map of different free food resources for community members to look at. And those are all available through our website, communitiescount.org. And the dashboard that I mentioned is available on King County's website at kingcounty.gov/COVID/impacts, as well as the other site I mentioned is communitiescount.org. Obviously funded by a lot of different groups, and I really want to acknowledge our full team. I'm just the one presenting today, but there's a huge team who works closely with me. So thank you very much. And with that, I'm going to pass it on to Sargis.
Hi all, sorry, I need to learn how to share screen. All right, is that visible to everyone? Yeah, okay. Hi, I'm gonna, I put these slides together in the last 30 minutes, so it is not very fancy. Most of it is just focused on previewing what is currently available on our website and several different dashboards, as well as kind of more how we look at stuff internally. And then I'll briefly talk about what we use the data for and how we have changed our data collection and analysis techniques throughout the outbreak, as well as what our plans are for the future. And then kind of some of the challenges that we've seen throughout the outbreak. So for just for context, we passed the 10,000 case mark this week. So right now we're sitting at about 10,300 plus confirmed cases. And this represents about 6% of all persons that were tested. And right now our testing has really expanded over the last couple of weeks, primarily driven through a couple of testing sites that have come up in Seattle that are free, and hopefully people are taking advantage of those resources if there are, if you previously had trouble getting tested. There's one in Soto and then one in Aurora, and I think UW is also hosting some as well. But our testing has really increased over the last several weeks. And right now we have tested about 1 in every 13 residents at least one time. So those are really good measures for us to continue, and hopefully we could get more and more people tested as they develop symptoms or come in contact with other individuals who test positive. And in terms of our epi curves, I think it's been pretty well documented nationally that there's been a kind of an uptick in case counts throughout the country, and locally we are definitely seeing a creeping up of cases in the last 2 weeks. It's our primary goal now is to really identify specific clusters and outbreaks as they happen throughout the county, and then try to figure out the best strategies to mitigate and prevent the spread of infections from those clusters, as well as identifying cases that were previously unknown due to lack of testing or lack of resources. So in the last 2 weeks, our primary, our most burdened geographic areas have been kind of the I-5 corridor in the South King County, South Seattle area. And that has kind of remained true since about mid-April. And on our website, if you kind of use this link below, there is kind of a toggle that lets you see how the geography has changed over time and where the outbreak has kind of gone throughout the last several months. So for this couple of slides, I'll focus on our race ethnicity data. It's been a whirlwind trying to get this information in. Just in case you haven't worked with surveillance data, race ethnicity was previously not a mandatory field for lab result reporting. So what that means is that we get lab results of positive or negative case results, and then we have to contact the individual and obtain race ethnicity information and language information from the individual through case investigations. And as case investigations get overwhelming, there are certainly large numbers of individuals who do not want to share that information, or we have trouble reaching because of bad cell phone numbers or emails, etc. So we had quite a lot of missing race ethnicity data, and we were able to do a lot of matching to our data sources, as well as there has been a change in policy statewide to mandate race ethnicity reporting for all COVID lab results, which has really helped us get race ethnicity data as the initial lab results come in. And the reason why this is really important for us to track is because we have seen how race ethnicity has shifted throughout the COVID-19 outbreak here in Seattle, King County, as well as where disparities have been across access to testing, where we've seen differences in how disease has spread or suspected exposure settings for individuals, as well as just overall burden. So when we look at the distribution of cases, white residents make up, close to a majority of our cases, but they also make up the majority of King County residents. So we look at both the distribution by just raw numbers of cases, as well as the rates. So when we compare the rate to the percentage and distribution, we see that there's a really large difference between several race ethnicity groups. Primarily, we look at the Hispanic and Native Hawaiian Pacific Islander groups, where the rates are 4 to 5 times higher than our white residents. And in terms of the overall population, we see, and this data is available at the link that was also, I think, posted on the Zoom chat box. But you could toggle to look at cases, deaths, hospitalizations, as well as removing long-term care facility-related outbreak patients. So when we compare to the King County population, we see that for Hispanic Latinx community, which makes up about 10% of the King County population, at least in 2019. For COVID, as of, I think this data is good as of last Friday, 27% reported being Hispanic or Latinx. So that's quite a large difference from the overall population. And that's why the rate ends up being so much higher. And then when we look at our age-adjusted rates, rates for Hispanic and Native Hawaiian Pacific Islander are depressingly high compared to our white residents here in King County. And we've seen this trend kind of replicated in lots of different parts of the country, as well as the rest of the state. This trend has not really been reversing for a very long time. And since about a month ago, every other race ethnicity group has also become significantly higher in terms of the age-adjusted rate compared to the white reference group. So that is one thing that has really shifted in that every community of color is facing a higher burden of incidents compared to the white residents of King County. And we see this primarily with Hispanic, Latinx communities when we look at deaths and hospitalizations as well. For other race groups, the numbers end up being a little bit smaller, so the significance is a little bit lost in that regard, but we still see higher rates. And you could toggle between them and then kind of look at the more detailed and granular level on the website. I kind of wanted to share this because this is not necessarily on the website. We are working on reporting this in a more elegant fashion for general audiences, but I wanted to kind of show this because I think it does describe some of the outbreak pretty well. Especially here internally, we do a EPI report every day to our internal audience, which includes all of our clinical staff, our government policy staff, as well as our data analytics staff, to kind of go through what trends we're seeing, where we are seeing high positivity rates, where we're seeing lack of testing, which communities are being outreached more, or we're seeing the effects of our community outreach and where we're not seeing them, and then trying to retarget our interventions and policies to best address the current level of the outbreak. So if we look at this kind of line chart that is very squiggly, we see that in the beginning of March, the majority of our cases were among white residents. And around this time, our outbreak was heavily geared towards the long-term care facility environment, as well as kind of the healthcare environment. And in our long-term care facilities in Seattle County, the majority of residents are white, while many of the employees are people of color. So as the outbreak became more generalized and as businesses began to close, as well as lots of individuals were able to work from home, that started shifting where the burden of the outbreak went. And not everyone was able to work from home in similar capacity. So as we peaked in the beginning of April, we see this shift where the Hispanic Latinx community overtakes white as the plurality of our cases, and that continued throughout most of May. And recently there has been this shift. And this is showing the total number of cases. And when we look at the rate, we see this, where the actual disparity really lies, where even though the Hispanic community makes up the highest race ethnicity group on any given week in May, in terms of the rate, it is 5 times higher than the white group for those any given week. So even to date, for the last full week, which was June 21st to June 28th, when we look at rates, for white residents, it's actually the lowest rate for the county at 13.6 per 100,000 new cases for that week, compared to our other race ethnicity groups, primarily when we look at Hispanic, Black, Asian, American Indian, Alaska Native, and Native Hawaiian Pacific Islander, where it ranges from 2 to 8 times higher on a week-to-week basis. So I kind of wanted to touch on that a little bit as well. And this chart is a little bit more intimidating, but it is mostly just to highlight what our current concerns, and then where we're seeing a large uptick in cases. Currently, with lots of things going on in the county and nationally, there has been a lot of uptick in cases, particularly among the 20 to 29 and 30 to 39-year-old age groups. And when we look by race ethnicity, we actually see this really large, I think it's about a 6 or 7 time increase, 7% increase, or 7-fold increase from the peak in April among white residents aged 20 to 29 years old. So, and we are tracking a lot of the shared exposure settings, and as well as trying to figure out what policies or changes need to be made in terms of, where people are getting affected. Is this a result of increased testing? Is this a result of increased transmission? And as we reopened more bars and as we move through the phases, how are those affecting our case workers and policy that kind of work within that realm? But our general dashboards have extremely high viewership across. And in the beginning, we were also getting a lot of viewership from national and international IP addresses as well. So I do think that there is a real hunger for data during this outbreak. And there are lots of people that are trying to make sure that data is driving the decisions that are being made for the county. When we released our key metrics dashboard, I think we had 100,000 views or something in like 2 days, which for a county website is nuts. But yeah.
Thanks, Stephanie. And I'll just add on. So the economic, social, and overall health, that dashboard isn't really targeted towards general members of the community. It's really targeted towards policymakers and people who can take actions. So for instance, yesterday we were talking to somebody who's interested in eviction prevention. So that is pretty darn cool, I think.
Yeah, that's excellent. That's what I suspected, that you knew your audience, and it was very intentional. So thank you. First question is, can you repeat what the y-axis is on the last graph, the number of cases?
Yeah, so I'm assuming this is the age and race ethnicity kind of trend analysis one. Yeah, so that is looking at the number of new cases for the 7-day rolling average. And that is just a way that we use to kind of quickly look at where we're seeing the burden, and then we have a bunch of different dashboards and different data analysis that we do more in depth. look at. But that's kind of just a high view maps I would look at.
Great. And then there was a question, is the squiggly line graphic available to the public?
Lots of things are kind of in development. We have like 1 trillion priorities, so we're trying to juggle everything. But I think right now it's not. But we are hoping to have more and more information publicly available either in Excel or in dashboards.
Great. And another question about the squiggly line graphic. Is it in a 1-week time period? And if the white 20 to 29 are the highest rate of current infections, what actions will be taken to curb the transmission?
I could answer part of that, and I have no idea about the other part. But yeah, it's on a daily, on any given day, the 7-day average of incidents. And then in terms of actions, I think what we're really trying to figure out is where transmission is occurring. Is it out of people traveling? You know, we do case investigation and contact tracing for all of our cases. So we gather information from people and try to link them together. Lots of the decisions really rest on our health officer as well as a lot of other governing bodies. But the decisions are made off of, you know, are people clustering in places? Is it something that we can make a change for, or is it something that people are not being able to adhere because of other economic or social barriers? And then it really just depends on what trends we end up seeing. But I will say there's also been a lot more testing that was readily available, so that has definitely helped in terms of case finding. So hopefully we're also just finding more cases, and that's being reflected as well.
Great, thank you. Are you able to run a regression analysis of race and age over time?
Yeah, we have. It's gotten younger, and it was previously more Hispanic, and I think things are changing now. We have, we're very fortunate in that we also are collaborating with the Institute for Disease Modeling in being able to do disease forecasting. And they have also been looking at trends or some models based off race, ethnicity, and age. And it's kind of showing, you know, it kind of shows what the data is, which is it moved towards younger age groups as we went beyond the long-term care facility settings. And for once work from home and people who were able to be at home and stay home got shifted towards people who were in essential work, which the demographics for individuals who have who are employed in positions where they cannot work from home really was reflected in our COVID cases. So.
Yeah, thank you. This is an interesting question because I know I've heard others talk about the density of households, and for some households it's just impossible, especially multi-generational households and households where there are more members. It's really difficult to actually fully isolate. So this question asks, do you have a sense of the contribution of household transmission?
Yeah, this is something that we have been tracking for a long time, and it's one of the major challenges as to prevent the outbreak has also been to how do you isolate family members from each other when they cannot isolate themselves within the house. So, you know, King County has provided, or has at least attempted to provide individuals who are willing housing in some of our quarantine sites and isolation sites. And earlier on, it was definitely easier because there was less infection. And as case counts went on, it became quite harder to accommodate every single person. But we do track it. Right now, I would say it's about 25% to 33% of our cases have other people in their household who were also ill. The temporal aspect of it is the most challenging, to figure out if individuals are actually getting sick from each other, which is very likelihood if you're living under the same roof and cannot properly isolate or quarantine yourself from each other. But we have lots and lots of households, many large households with more than 4 or 5 people, and multi-generational that have reported many cases. And but individuals also reported working a job that required them to be outside, to take transit, to they are either it's through their work or through other sources also being exposed. So it's pretty tricky, but households are definitely one of the larger exposure settings.
Yeah. And then do we have time for one additional question or a couple of additional questions, Hilary? Okay. Let's see. Do you think you're not finding cases that are actually there in people aged 20 to 29 other than non-Hispanic white? I think that's the NHWP, non-Hispanic white population, because there's less testing. And I don't know if that means less testing available or less testing happening or being sought.
I think I'm not sure there's a definite answer to that, but there are definitely some concerns over whether testing is equitably distributed throughout the county, and there are lots and lots of time that we're dedicating since the beginning on just figuring out which areas by census tract, by zip code, by city are being tested equitably across different race, ethnicity groups and age groups. In the current status, I would say testing among 20 to 29-year-olds has really increased. And I think a lot of this I know most of it is led by the free testing sites that were put up in Soto and Aurora through the former emission sites. You can look them up if you need testing, or if you know people that need testing. They're great resources. But those facilities have, I think, right in the last 2 weeks have been about 40% of our tests, and they've been in addition to the previous testing capacity that we had. So they didn't necessarily take away from the testing capacity that we were previously seeing, but added to it. So I think to answer the question, I think people weren't seeking testing or weren't able to get tested previously. Now there are more opportunities that people are getting tested, but there's absolutely more need for testing and more need for easier access to testing across language groups, across age groups, and across race ethnicity.
Thanks. Yeah, that's a great setup for the next question. The question is there an effort to modify messaging to address different race ethnicity groups? And I know that I think you have some of your messages in 30 or so different languages, but I'm wondering about different approaches, different types of messaging beyond just language and translation.
Yeah, I could talk about it. I don't know if Eva has anything more specific for other things, but we partner with a lot of health boards that are community-based health boards, and there are a lot of different calls that we're on weekly with different community members that are parts of, some of them are faith-based, some of them are race ethnicity, some of them are disability, some of them are business-related, housing-related, et cetera. So we try to reach out and collaborate with as many people as we can. And the resources here at King County are pretty great. I mean, I think in terms of a public agency, there is a lot of attention spent on creating partnerships over the years that are really paying off during this crisis. There's still much more that could be done, but there are lots and lots of partnerships that have been created over the decades that are being leveraged at the moment. And Lots of partners are on calls weekly and getting as up-to-date information as the county has. I don't know if Eva has anything to add.
I don't have anything more to add. Thanks, Sargis.
So I have a question. You mentioned that, and I guess I hinted at, that Public Health Seattle King County has, is well-resourced in terms of having epidemiologists and have, as you said, have over decades partnered with community-based organizations, have put a lot of thought into this type of work and are able to respond to a crisis quite holistically and quickly in a concentrated way. Do you have advice, or have you thought about, or have you worked with other health departments, small health departments that don't have the same capacity? Are there a couple of different data points that you think are the most important for them to track, or a couple of actions that they should take with their community members to make sure they're most protected, given stretched or limited resources in a smaller health department?
Yeah, I would say regardless of how well resourced we were, when COVID started, I think being the epicenter of the national outbreak initially, when so little data was available from the United States, as well as lots of policies and recommendations on what to do were not available, I think it was very evident that public health as a whole has some funding issues as well as some preparation issues. But I think for smaller counties, it's been a real challenge. I think for the state of Washington particularly, the Department of Health at the state level has really taken on a massive role in helping lots and lots of the smaller jurisdictions. I would say even for us, we're the largest county by far, and certainly well-resourced in many different ways. We also are relying on the state to do lots of different things for us. They are still doing, 30 to 40% of our case, or they're still helping with some case interviews and some just general, we collaborate with them every single day on various different things. So I would say the hardest part is to be able to use the data, you really have to have good infrastructure and good informatics built well before a crisis. It's really hard to stand up massive systems, as I think it's been obvious nationally with a lot of our contact tracing efforts. It's really difficult to stand up these large infrastructure and informatics measures in a short amount of time. And when we allocate resources, I think there's a lot of trouble with what to focus on. And when you have smaller jurisdictions, I think it's you really have to start relying on other people's expertise and partnerships with either private, educational, or larger state or federal agencies. Yeah, I'm not sure if I have any specific advice other than, kind of try to collaborate with as many people as possible and try to leverage any other expertise in the area.
Yeah, no, that's great. That's really helpful. There are two additional questions. I know we have a few announcements to make about back to campus, back to work. No, we don't. Yes, we do, but those are sent out on email. So
we do, but we can hold them. People should just check their emails. I would prioritize answering the question. Okay,
so everyone just check your emails for how we're going back to campus and moving into a new building. It's very interesting. One question here, what's your sense of the contribution of travelers, i.e. residents returning or non-residents visiting?
Yeah, that was not an issue for a bit, but as things have reopened up in various different settings across the country, we are definitely seeing a lot more of an influx in travel-related cases, particularly in some of our neighboring states, as well as some of the larger states that are seeing really high incidence rates right now. The hardest part, I think, as in this role and in describing the outbreak is that everyone has many different exposures. Individuals who went to Arizona to visit family or friends also had individuals here at home that were sick that they had contact with. They've also gone out here or done other activities that may put them at risk. So it's overall really challenging to kind of have one particular exposure. But I would say travel has definitely started to become more and more of a concern in terms of being an exposure. International travel has obviously not been a big of concern since the very beginning, where we were seeing mostly travel-related cases, but now it's mostly just domestic travel, particularly in cases that are coming from areas that are in high incidence rates right now.
Yeah, I was listening to a piece this morning that said you can't absolutely get rid of risk. That wasn't the phrasing, but you can minimize risk. So you can't get rid of risk, but you can minimize risk because there are just so many different ways to be exposed. And this question is maybe similar. Have you identified some activities that are particularly risky? For example, going to casinos, riding buses, etc. And I guess there's a similar question about point of infection or point of exposure. Are we able to trace that accurately?
Yeah, everything has a level of risk. But yeah, I think our main goal right now and what our department is really trying to do is identify the most commonly named clusters to try to figure out how we actually want to address some of these risks. Because everything has risks, and there are, I think as Eva showed, that there are so many other impacts to this as well, that we want to be able to consider how do policy changes that maybe target a specific risky activity for the day also affect people in other ways that may not have been really the intention or the true concern. So we are tracking, activities in bars and restaurants and casinos and transit, travel, healthcare work, all types of different things. And I would say right now our primary things that we're seeing is, lots of young and within the more urban settings, in Seattle particularly, we're seeing a rise in cases. But we're also seeing, a rise in testing. And I think anecdotally, we're also seeing a lot more people out and about, and there have been reopenings of restaurants and retail stores, et cetera. So I think just general community gatherings are becoming more and more common. And that is also a very, that still remains a risky behavior, large gatherings at home or celebrations, et cetera.
Yeah. One thing that I was so happy to see is, we talk a lot about testing and transmission and infection rates and morbidity, mortality rates. When you posted the social, economic, and overall health outcomes of mitigation efforts and policies, that was something that we hadn't talked enough about, and so I was really pleased to see that you're focusing more and sharing more information about the impacts of trying to intervene or mitigate the effects of COVID, and that the impacts of the mitigation efforts in and of themselves are quite disparate in terms of who's affected more. So thank you for that work as well. You have 6 dashboards now, and I'm sure you're thinking of the 7th dashboard. So thank you both, Eva and Sargis. Appreciate your time very much.
Yeah, just to close out, just want to echo Stephanie's thanks from all of us, both for the great presentations and then to you and all of our practice partners for the just amazing jobs that you've been doing here in Seattle and King County, but across the state of Washington. We're just incredibly grateful and particularly happy that you were able to take a little bit of a break from your hectic schedule today and spend some time with us. Obviously, people have lots of questions, and it was great to have you share some of the latest information and your latest thinking. So with that, the only thing that I saw, I was flipping through our updates to see if there was anything that was time sensitive. And the one thing that I saw was that I know Lisa had wanted to mention that we have another round of funding for COVID-19 population health grant. Do you want to say quickly what that is, Lisa?
Yes. So the Population Health Initiative has released a third funding opportunity. These are COVID-19 population health equity research grants. They are intended to support projects where UW researchers partner with communities of color to develop projects that address community identified needs. It's the same format as the other PHI small grants opportunities. They'll award up to $20,000 per project for a short time period, 5-month award period. The School of Public Health is committing to provide the same amount of matching that we've provided in the past, $20,000 match per project, or I'm sorry, $15,000 match for proposals where the public health faculty member is the PI, and $5,000 where the public health faculty member is a co-investigator. Proposals are due on July 31st, and please get your requests for matching to me no later than 5 p.m. the day before on July 30th. We've had really great success with these. The equity grants are really important always, but particularly so right now. So we really encourage you to get together with your community collaborators and submit a good idea.
Great, thanks, Lisa. So just to close, huge thanks again to Eva and Sargis and for presenting. Stephanie, huge thanks for organizing, bringing in Eva and Sargis, and also for moderating a great session. And hope all of you stay healthy, and we'll see you next week.